But the most important issue to clarify, for instance, let's just talk about a couple of these male problems, just so you have some tips about how to treat them if they come your way. The most important issue to clarify is whether a man with premature ejaculation can differentiate his premonitory sensations. Those are the sensations like, hey, I'm getting pretty close. I feel like if I keep this up, I know I'm going to come. So, increased heart rate, increased respiration, kind of a tightness in your butt, your toes may curl or splay out. From emission is when the fluid is deposited remember I used my fingers, at the base of the penis, and then 2 to 4 seconds later, striated muscle contracts rhythmically and fluid is spurted out. Whereas the guys that try and hold it back will end up with a partially retarded ejaculation where it sort of just dribbles off the top. It's because of these different stages. They need to learn about that. So premature ejaculation patients usually relapse when withdrawn from urological treatment. So there's a lot of drugs that can be used, creams, lotions, potions, that will help delay ejaculation, that will affect the intravaginal ejaculatory latency time, is how it's described in the research. But typically, when they go to see the urologist and they stop using the product that they've been given, and sometimes even with that product, if they have a severe problem, they'll go back to the urologist, cancel the appointment, ask for a referral, and that's where you can come in. Medical approaches, whether they're pills, topical creams, sprays, emphasize symptomatic improvement without considering long-term learning, relationship issues, or the relapse with discontinuation. So they usually relapse when withdrawn from these treatments, and that does generate the referral. Medical approaches, we're not changing the slide here. There we go. So what does he have to do? He needs to recognize a clue before it happens. He often doesn't realize when he says uh-oh, I'm going to come now. He's actually coming. What's happening is he's confusing his emission, which is the first thing he's noticing because of anxiety and a lot of muscle tension, because he knows he's going to come quickly, and he's hoping he won't, but nonetheless he's tense. So what bursts through that tension is actually the emission, the depositing of the fluid. So he feels that and he goes, uh-oh, I'm getting real close. But in reality, it's not, uh-oh, I'm going to come now. It's, I'm in the process of coming now, and 2 to 4 seconds later, fluid's going to come out. And if you try and hold that back, it's just, again, going to dribble off the top, and then you'll lose your erection. So I wrote an article for Psychology Today, why premature ejaculation is a reflex like a sneeze. If you have to sneeze, if you feel that tickle and you blow your nose, it's all fine. But if you wait till you're, and before you hit chew, you try and blow your nose, it feels like you're blowing out your eardrums. This is much the same way. It's a reflex. So men confuse their premonitory sensations and the submission phase. And it's really too late then for him to stop or slow down. So sometimes I'll use a yellow light, a green light, yellow light, red light analogy to help them understand. It's not like New York where you had a yellow light, you drive faster so you can get through the intersection. You hit a yellow light, you better stop initially, pause, get the lay of the land, and then start again slowly. And then gradually you can shift into that yellow light. You can slow down, you can move in a different way, you can change positions. So it's a gradual approach to teaching him. When it's a really severe case, then I will ask for the person who referred, the physician who referred to me, to prescribe whatever they feel might work best, and we usually discuss it. That would help physiologically slow him down, because these are people who are typically predisposed to this particular problem. And he's got to reset his threshold, reset his ejaculatory tipping point, if you will, so that he has the time where everything's moving a little more slowly so he can recognize those more subtle sensations in his body and do something about it. Then once he learns to do that, we can start reducing the use of the medication. And once accomplished and differentiation is established, you can take them off the medication and they will not relapse, unlike the urological treatments. So moving along, here's my thoughts on the future of ED treatment, as shown in this cartoon. What it describes is an integrated treatment for ED, secondary to, these are men have a metabolic syndrome. You can see Fat David on the right side, all up in the air. And a PD5 is integrated with sexual counseling and a little luck from the hand of God. You can't just think, oh, this is going to work because you're clever. When I first made this slide, though, interestingly, I presumed the new drug that would get developed would be some kind of a new drug for erectile dysfunction. It turned out what happened before that is we've got Ozempic and people are losing weight. And so they're in better health, at least physically, feeling better about themselves. Whether or not this helps ED or not, we haven't researched that. I have no idea. But there's no question there'll be continuous evolution of these treatments. And yet all of it is going to require the kind of counseling skills that all of you have.